Hi, my name is Maggie Ugelstad. I'm a computer science major here at Wellesley, and what a privilege it is to introduce our prestigious guest. Ophelia Dahl began her interest in healthcare for the poor in 1983 whilst volunteering in Haiti after her pre-college education. That same year, she started a conversation with colleague Paul Farmer that has now formed to become what is known as Partners in Health. As co-founder of Partners in Health, Dahl's organization has, in 2018 alone, reached 1.6 million people, providing them with hope in healthcare. Dahl served as executive director of Partners in Health from 2001 to 2015, and currently is the chair of the board of directors, helping Partners in Health continue to build healthcare systems in remote areas of the world and to raise standards in global health. Dahl graduated from Wellesley College in 1994 as a Davis Scholar and has recently become a trustee of the college. She is also a Director's Fellow at MIT's Media Lab and is Vice President of the Roald Dahl Museum and Story Center. Please welcome back our Wellesley alumna, Ophelia Dahl.
Thank you.
My name is Frances, and I have the privilege of introducing Dr. Jaya Gupta. Dr. Gupta is an alumna of Wellesley College, where she majored in international relations, political science, and minored in women and gender studies. She was also an Albright Fellow. After Wellesley, After Wellesley, Dr. Gupta worked at the Institute for Global Health and Development at Brandeis University and went on to receive her PhD in International Health and Master's in Public Health at the Johns Hopkins Bloomberg School of Public Health. Dr. Gupta is now a health system strengthening specialist with extensive experience conducting mixed method research in North India. As part of her research, she has evaluated nurse mentoring and training intervention in order to improve the quality of care that people receive. Dr. Gupta previously managed nutrition interventions and led monitoring and evaluation efforts for the health division at Seva Mandir, a non-governmental organization in Udaipur, India. In her dissertation research at Johns Hopkins, she studied the impact of a variety of factors on health worker motivation within the context of organizational psychology. I'm so excited to welcome Dr. Jaya Gupta to be here with us today. Thank you.
So I'd like to just begin by thanking Frances and for the kind introductions, and it's really an honor to be here speaking with Ms. Ophelia Dahl. As many of you know, she's really been a pioneer in public health, and as somebody who's embarking in my own beginning of my own public health career, it's truly an honor to be here speaking with you. As many of us know, Partners in Health has inspired a decade or more of public health practitioners, and I hope that Ophelia will have the chance to speak a little bit about her work. And I actually had the opportunity to first hear her when I was an Albright Institute Fellow back in 2010, and it happened to coincide with the Haiti earthquake. And as we all know, Partners in Health has spent a number of years since rebuilding the health systems in Haiti. So that's, again, another thing I hope we have the opportunity to speak about. And if I recall from my own time as an Albright Institute Fellow, one of the things that really struck me and really resonated with me was learning about the different individuals at the helm of their respective organizations and really learning how their life experiences have shaped their identity as a leader. So while I do want to speak about Partners in Health, I also hope that we can touch upon some of these aspects as well. And so, yeah, what we'd like to do is have a conversation for about 50 minutes with some questions that I prepared. And we'll turn it over to you all, students, who I'm sure will have some questions and can continue the conversation in that direction.
That sounds great.
Yeah?
Yeah.
All right, so
I just want to say one thing apart from how lovely it is to be here talking to all of you, and you, Jaya, as well. That first time that I came to speak at these Albright sessions, it was just, as you know, right after the earthquake, because the anniversary was the January 12th. And it was, I remember it so vividly because of what was going on and what we were trying to help with, but also just the sort of how lovely it was to be back here and to feel surrounded by a group of people who, it felt like you were all colleagues in many respects. And that's why that particular time was so important to me.
Yeah, and it was a very unique session as well because it became essentially a press release. And so there was a number of media people in the room, and it was really the first time you had addressed the public since the earthquake, I believe.
Right.
So it was quite a special time for us as young people to see how quickly you have to have a call to action. So that was really, really an interesting time for us as well.
No, it would be great to delve into it a little bit, that response, if we have time.
Yes, absolutely. So I'd like to just begin starting with Partners in Health and talking a little bit about their philosophy to global health. So the byline does read, we go, we make house calls, we build health systems, and we stay. And I believe one of the distinguishing factors that is specific to Partners in Health is this concept of the house call. So I was wondering if we could begin by talking about where this principle stemmed from and how it has really been practiced by Partners in Health.
Yes, well, I would say that one of the things that happened early on in Partners in Health is that and I'm not sure exactly how much all of you know about it. I know that you all had a chance to speak with and hear Dr. Reagan Marsh yesterday, so you know a little bit about our time in West Africa over recent years. But we started a long time ago and got our start working in a very small village in central Haiti with a group of essentially water refugees, people who had been displaced from their land because of a big hydroelectric dam project, and they had been forced up into, they had been given no compensation and been forced up into these very inhospitable hills, mountains. So when we started working there, having been invited there by an Episcopal priest who'd been working in this area for a long time, Paul and I, we were just sort of getting to know the lay of the land. And Paul's background at that point was in anthropology. So he was in the midst of doing his ethnography, and we spent a lot of time getting to know the area and with some of the Haitian people who became our colleagues, walked around from house to house. And we realized pretty soon, as we started trying to help to build a little bit of infrastructure there, guided by our colleagues, that there were many, many barriers to being able to, for people being able to come into a clinic, even if you built a clinic or even if you built a hospital. It was clear that there were numerous barriers, people being too sick, people being too poor to be able to leave home, childcare, people having to choose between actually getting care in a clinic and going to market. So all of these trade-offs were happening, and we realized that after a while of doing this, and we actually did a study around tuberculosis care, and the group that we helped to get the actual medicines to them in their homes did far, far better than those who had to make the trek to a clinic. So we realized, I remember being a kid growing up in a village in the countryside in the UK, and we were ill. My mum or dad would call the doctor, and the doctor made a house call. They would actually come to your house. It's so preposterous to think of that now when you think about the 7 minutes you get with your PCP, if you're lucky. But yeah, they'd come and they knew us, and they'd have a drink and we'd chat and all of that kind of thing. The house call around getting to know the community is very important. And so we also realized that if it was going to be community-based, we would need people to deliver care and accompany the people within the community. So that felt like a very, very important part. It was sort of part of the philosophy of lifting barriers and realizing that if the goal is to get people good care and they can't actually make it into the hospital, it's true here. It's true in any health system, being able to make sure that care can be delivered also in the home so that the emergency room doesn't become the default place where people are seeking care that they don't need to be at the emergency room for.
Yeah, and I think you raised a really important subject that I've seen in my own work in North India, is this concept of trust. And I think there's a lot of misconception that people, especially poor people, are unwilling to seek care because of costs, which of course is a prohibiting factor, but actually a lot of times what I've heard is really this distrust in health systems. And like you're saying, engaging community members and really taking a community approach can really help overcome some of those prohibiting factors. So that's very,
It's true. And it's, one of the things that have been cited with us often is but then how do you pay community health workers? Is it sustainable to be able to do this? And, you know, again, I think if you keep your eye on the idea that this is really about getting patients well and delivering good healthcare, and not sort of lead with, is this cost effective? Is this sustainable? It will often, you'll find the answer in that. It just means it's harder to do.
And you raised this question that I think is something I really believe strongly about, as Frances was mentioning, my own dissertation work related to how do we motivate and retain health workers. I think they are a critical component of any health system, and typically with health interventions, they're the largest byline as well. We are spending the most on health workers. And so one thing I wanted to ask you about in your work with Partners in Health is, how have you seen health worker motivation, retention, be factors that are important? And in your experience, how have you thought, what do you think would be really important to change that, to improve motivation?
Yeah, you know, it's one of those things, and part of this goes back to the long game, the idea that if you can be in something and see results over time. One of the things that we found, and we work in, Partners in Health works in Malawi, in Africa as well. We work in several places, several countries in Africa. But one of the things that I remember when I first went there and I heard the statistic that there were more Malawian nurses in Birmingham in the UK than there were in Malawi. So, you know, as we sort of thought about how is it, we can't make this a system around whether or not we have interested volunteer doctors and nurses to come and create a healthcare system. How can we actually just address this? And I think part of the answer lies in the idea of building a system, and part of that is in the training, and part of that is making sure that people have everything like access to salaries and being able to live in places and make sure that their kids can go to school in those places. So again, you know, most of this is really, we could spend a couple of days together actually just hearing from Jaya's experience, not even mine, in terms of the complexity of this. And I hope we can kind of get down into some of that complexity with some questions perhaps, or the discussion. But the truth is, if you actually provide the kinds of things that any of us would expect with our own careers, and then people generally want to stay. I've not met a Malawian nurse in Birmingham who's like, I just love being in Birmingham. I'd rather be there than, you know, than in Malawi. But what's not offered there is a kind of, you know, robust public sector, you know, regular salaries, training, professional development, all of that kind of thing. And it sounds like an enormous sort of chunk to bite off, but that's really what's necessary. So we've been involved over the years with, and it's partly why we partner with the public sector, and also why we're involved in building a university to global health equity in northern Rwanda, and that's, you know, because we're trying to change systems to make sure that a lot of these places that we're working that don't have robust systems have been, you know, are very much a part and parcel of their history. And, you know, imperialism and colonialism and civil war and genocide, you know, there are many, many complicating factors, and to build back from after that takes time. And I think sometimes the patience and willingness to stick with that for a long time has to be there as well. So, you know, jobs and being paid, and some of this stuff, you know, it involves coming up with really unusual ways to make sure that that happens. So as, you know, I just think about the ways that we've come up with trying to make sure that the ministry has funds to be able to do that. And that, you know, one of the things that we did after the earthquake in Haiti, we'd managed to raise a lot of money, but many other organizations, much bigger than Partners in Health, had also raised a lot. And there were whole groups of people, healthcare workers that were Haitian, that were not being paid because the civil service had been destroyed. So, you know, is it PH's job to create a pay structure and pay role for some of these physicians, clinicians, nurses, you know, all of supply chain people, pharmacists? And we worked with the Red Cross to try to make sure that we could do that, so there was no interruption. And you know, that's a complicated thing to do, because if you don't have a system, you know, the Red Cross said to us, and this is not the Red Cross, it's like people within the Red Cross said to us, but how can we prove that these people are actually turning up for work? because we can't use our donor money unless we actually have a punch clock. So we said, we'll buy a punch clock. You know, some of these answers are relatively simple, and some of these answers, when you get stuck in a bureaucracy, it's like, we can't do this, we can't spend our donor money like this. And other things, it's like, you know they're coming to work, they're dying to come to work, but they have to be paid. And if they don't get paid, they're going to see private patients on the side. So it's being a little bit flexible in your thinking, which is harder to do as part of a bureaucracy, but easier to do if you're part of a flexible NGO.
Yeah, no,
does that get to a little bit?
Very much so. And I think you've raised a really important point as well with, I think, again, going back to people's assumptions about health workers. And in a number of places, especially in resource-poor areas where they're working, they're highly, highly internally motivated. These are people who are oftentimes working with 6 months no pay and, you know, really... Yeah. They, you know, finding flexible and adaptive mechanisms to find a way to pay them, and especially conflict settings or post-disaster settings is very important.
Yeah.
They're oftentimes neglected in lieu of other things. And so that really does bring me to my next question, which is something I know you and other folks at Partners in Health have been quite vocal about, and that is the fact that health funding has not historically been channeled directly to health systems or local governments. And oftentimes they're in favor of non-governmental organizations or other types of institutions. And so I wanted to know, as somebody who studied health systems, I do believe that strengthening health systems is the way towards a sustainable, more resilient, and more responsive health workforce and other parts of the health system as well. So why do you believe there has been such a hesitancy to invest in health systems directly to local governments? And that was my first question. And the second is, as Partners in Health has, you just mentioned, worked with local governments, how have you overcome some of those challenges and the perceived barriers?
So I think the first part of your question is sort of why there's so much reluctance. I think because, particularly amongst NGOs, is because it's really hard. Mm-hmm. It's easy to be an NGO, small or relatively large, if you can make up your own rules and you know, adhere to your own mission and just deal with donors. Working with governments in the US or Europe, or indeed in resource-poor settings, it's just difficult because it's harder to work with bureaucracies. But one of the things that we've found, so that's why I think it's mostly because people it takes a long time, and you meet resistance, and then you I mean, and it's really a lot of these things that I've gotten to know, and I'm sure you're familiar with this too, Jaya. But it's, you know, you have a meeting with someone in the middle of a village, whatever, and then you know you're ready to go there, you're ready to set a budget, you're ready to do whatever it is you have to do, and then they don't turn up, and it turns out that they don't turn up because, and they haven't contacted you because they don't have any cell phone minutes, or they couldn't find transport, or and this is some local government people and that kind of thing. And when this happens 4 or 5 or 25 times, and it's not about unreliability, it's about, then you have to say like, this isn't, I don't believe that this is about a sort of, non-motivation or anything. It's like, so how can we do this? How can we partner? Because whenever we have done this, we have found enormous willingness. People join the civil service generally because they want to see results. They want to be, part of the solution and that kind of thing. And it's, it's not to say that there aren't sometimes problems with it in the same way that there are in this government. I think 2 or 3 years ago, I said this to some students here that, when we think about corruption and that sort of thing, it was at the time, of course, we sort of immediately go to places like Malawi and imagine that it's very corrupt. And I think at the time there was something like 2 or 3 attorneys general from even New England that were either in jail or had been indicted. These are like the top lawmakers of New England. And, we have a tendency to go straight to sort of like, oh, that country looks like it might be corrupt. And it is, I'm not romanticizing it, I'm just saying there's a bit of it everywhere we look. And so not letting that be a barrier, but also focusing on those people who've joined governments or joined, any kind of an effort to make things better and realize that that's what they want to do. And you all, and we all, who have been socialized in some really important ways for success, can lift barriers in all sorts of ways to do that. So I would say, finding people within governments to be able to do this, larger bureaucracy to partner with is the way to do it, and not to sort of throw up your hands when it's like, I just can't believe they didn't make the meeting 2 or 3 times, instead of sort of looking at why they didn't make the meeting and that sort of thing. So, you know, bureaucracies are much harder than working with a small group of friends. And one of the things that was so easy about starting Partners in Health with people that you love and trust, and, you know, apart from being able to do things like take risks and all of that, is that you don't have to ask permission. If you know, I'm sure there are people here that you've gotten to know very well and you can talk in shorthand. You can't do that with people that you're first beginning to meet. But as all of you know, I imagine, I'd like to emphasize, almost all of the work that all of us do, wherever it is, you know, certainly not just in healthcare, but whatever, but even more so in this kind of work where we're trying to change minds, influence people, bring people along, is human relationships. Mm-hmm. It's absolutely core of everything. And so that is the case also in governments. And, you know, from the highest level all the way to, you know, people who are working at the very, very, the sort of less influential district level, who might be a district health commissioner, who are really looking for ways to try to be able to get things done for the community they're representing.
Yeah. And could you speak a little bit more about this concept of building human relationships and how that looks like in action? So especially maybe at the top level and then versus at, you know, maybe a lower level as well. Yeah, so at the top level, for example, I mean, again, none of you here, I know, because you're all here, need a lesson in human relationships, or how to build them, or how to be friends with someone. But it really does, I think, come down to that sort of building trust, and as an organization sort of thinking about that top level. I'll give you an example. When we were first invited to Rwanda in 2005, PH had been working for almost 20 years at this point. And we arrived in this sort of about 2 hours east of the capital city, Kigali, and this is where the government had asked us to go. Again, Rwandan government, very strong compared to many governments where NGOs just turn up. They literally, well-meaning, extraordinary NGOs, they just fly to countries and they just turn up and they say, okay, we're here to help. And they just go to different places and they do their thing, entirely untethered to other organizations. So it's like, and then they work very, very locally. You know, we're going to build a school, and everyone's like, oh, great. And, you know, but it's not tethered to anything else. So I give that context because in Rwanda, there were many, many NGOs that turned up post-genocide, all of them, I'm sure, hoping to do good things, many of them funded by our own government. And so, you know, with much of that money staying in DC, 70% overheads a lot of the time, and then a group of people who'd fly over, often stay in capital cities because that's where the electricity is, that's where it's easier to get stuff done. And, you know, the Minister of Health there, who we got to know, said it's just amazing. They just won't leave there. And there was something like 12, no more, like dozens of organizations and NGOs, US-based, that were working on HIV treatment, or HIV in general, research treatment. And there was something, please don't quote me on this, but it was something incredible, like 20 patients on ART. I mean, really, it's like, it's so topsy-turvy you can't even imagine it in some of these places. And they're doing research or whatever. And the government of Rwanda, the Ministry of Health said, look, we're happy to invite you here. You can stay. We have a plan around HIV. We have a plan around healthcare. We have a plan on building a primary care platform. If you would like to stay, here's where we would like this, you know, you to go. Here's where we'd like Catholic Charities to go. Here's where we'd like, you know, this group to go. And many of them left the country because it's so difficult to be able to you know, corral groups of people who are used to being able to do what they want to do. And so I know I sound a little bit incredulous, but it's still so amazing to me because I'm trying to imagine if like someone turned up at Wellesley College and said like, okay, well, we're here to help. We think we can. No, we got that. We know we could use maybe some support, but hey, you know, and here's where we need the support. But that happens, and it's part of this whole kind of, you know, gradient of inequality and all of that, the sort of the gap. But so
so that's on the big, so we got to know the Ministry of Health. The big thing is that we were invited to the country. The place that we haven't been invited to was Haiti, and that's where we did turn up as volunteers all those years ago. But all other countries we've been invited to, so we immediately, when you're invited somewhere, you get to know someone, and at the higher levels we got to know the ministry, and then we said, how can we help? You know, we have some experience in doing this and this. Is that helpful to you? And they said, yes, but we don't want you here, we want you there. And so then we built up relationships with the higher level people, and then the district health commissioner. And then as we sort of, oh, I know what I was going to tell you. I was going to tell you the anecdote of arriving in this place called Ringwavu. There was already a clinic there, built in the 1930s, and it was a clinic that was actually for expats who were mining in the region. And as soon as the mine did its thing and finished removing its resources, they all left. The hospital had fallen into disrepair decades and decades later, and it was a clinic, but it was, I wish I could show you a slide of it. It was such a pathetic clinic. There was nothing there, and there were no patients because there was really no care. There was somebody who paid for something, and they were lying on a mattress on the floor, and they had an IV in, and that was it. And I remember talking to the district commissioner, or the person in charge of that particular area, and he was a nurse himself, and he sort of sat on the steps despondently, and Paul and I sat with him, and we were talking. We said, no, we'll be here, and we're going to stay. And he said, okay, you know, and he said, and we said, you know, what could be helpful? And he said, I was just really despondent. And I said, you know, we will stay if you want us to, and we can bring. He's like, yeah. And we got to know him over the course of a couple of days, and we said, you know, you seem really like, do you not trust that we will? He said, I cannot tell you how many times in my career I've heard people say, don't worry, we're going to be here, and we'll stay here, and we'll do whatever it is that you need. And then a year later they leave, or 6 months, or 4 years. They just go because they're posted somewhere else, or someone else comes in, or they run out of funds. So we got to know those people, and we're still in touch with them. It's almost all Rwandans. It's not the American piece, but it was gaining the trust and getting to know people. And that means actually building a relationship, building a friendship if it's applicable. You know, taking people out for a drink, getting to know them, getting to know their families, asking them the names of their kids, where they're in school. You know, we have now thousands of employees at PH, and I will be the first one to say I do not know everyone's kids' names. But that is important in building relationships, whether it's the Minister of Health or whether it's somebody who's been abandoned many times over.
Yeah. And you said something so fundamental there, which I think is oftentimes forgotten. I think we get so focused on our end goal, or you know, they say the tyranny of targets. And I think that one thing you really mentioned is just asking, how can we help? And I think that's a nugget there, you know.
Yeah.
To do that.
I think particularly because we're socialized, all of us, we're socialized to know what it is. We're supposed to be experts. I imagine that most of you feel sometimes as though you're supposed to be experts in certain subjects. And when you go away and do internships, you arrive, it's like, okay, I'm supposed to know what to do. And we sometimes arrive in places. You know, I've had this experience with wonderful Peace Corps volunteers, and we've sat in communal places in different places. This one was in Kenya that I'm thinking of, and these were, you know, young Peace Corps volunteers, and we're sitting with elders in the village, and they're like, okay, because they clearly had targets. They're like, okay, so here's what we're going to do, and everything. And Paul and I are just mortified. And, you know, it's like, ask the village elders who've lived their entire lives here what it is. Like, you can learn from them. But it's not, I mean, it is brashness, but it's not born of ill will. It's because everyone told them they should know what it is that they should know, and you know, and how we do this. So, you know, back to your tyranny piece of this, there is like, I actually want to, she's not going to want me to do this, but I want to introduce my colleague at the back of the room, Amy Heising, who also is a Wellesley grad, and we've worked together for almost a decade, at Partners in Health, and Amy came on right after the earthquake, actually as a volunteer, and we've been working together ever since. One of the things that we were talking about we spent a lot of time talking about this, is the idea of, you know, producing rather than a kind of purposefulness of this. So, you know, of course you all and I have to produce things, we do. You can't just sit around only, you know, chewing on thoughts. But I think there's so much emphasis on you all and us all producing things, getting stuff done, that sometimes all of that other piece is lost in the midst of it. And I think that's what happens with a lot of bureaucrats and foundation people and government workers. development people who come from DC and other places, and they say, okay, we're here to do latrines. And, then they go, and they check through their list, and they're not actually asking themselves, are we really helping? Do they need latrines? Do they, what else can we do? So I think a great deal of this work and your work, whatever you go into, and I'm not presuming that all of you are going to go into healthcare or international work.
Mm-hmm. Yes, and I think another thing you touched on in the course of this story was about this concept of cynicism, both on our side as perhaps people who are not always parachuting in, sometimes staying the long course, but also on the side of those who are working with and partnering with. And I think something I myself have started to encounter is a sense of being cynical, being jaded, especially when you hear stories such as what you mentioned of people parachuting in and out. And also when you're, it's very visible when you go to villages and you see vestiges of old organizations, the big tin thing that held the grain, or the old clinic that's
with USAID stamped on it.
The names are everywhere. Yeah, so it really is disillusioning, and that's something I know you've spoken out about as well. And how have you remained optimistic, and how have you overcome sort of cynicism in your own career?
Yeah, well, I'm not a very cynical person. I can be quite an edgy, dark person. I'm not suggesting that I walk into life sort of thinking it's all rosy, but I think maybe it's because I learned it through this work. I think that to be cynical is such a privilege. It's such a kind of crazy, arrogant thing to be on behalf of all kinds of people who can't afford to be cynical. So I think that is a part of it, and I don't know. I mean, it certainly doesn't mean I haven't sat in rooms, and I just was a little bit cynical, like USAID on them. That's cynical. It's optimistically cynical, because on the other hand, I also know that we can do something about it. So that the cynicism there is, I've seen it so many times where there have been these big development pushes into things, and then people depart. But I think, the other part of it is being fortunate enough to be part of an organization that doesn't allow cynicism. It's not part of the mission. It's not part of our vision, which is very different than getting down. Like, we get depressed by what we see. But so I think it's a practice. To be able to be cynical about something. I am, occasionally cynical about various aspects of it. But having said that, I think that there's, seeing results that happen, so being able to see progress over time is a great prevention to cynicism. If I saw no progress, and if my colleagues saw no progress, I think I'd feel pretty cynical. And I think that means you sort of have to stay long enough to see it. So, when I think about, whether or not it's, and Amy and I actually headed to Rwanda next week for the opening of the first phase of the University for Global Health Equity, and that, these are great antidotes to all of those things, to be able to go there and see the progress. I'm not involved in building that university. I've been involved in raising some of the funds to it, but to be able to go and see things happen and get built and progress be made on that large system scale, and then also to go back and feel as though you see other things happen on a human scale, whether or not it's the person that you met who had cancer, and it occurs to me actually when I'm with lifting barriers as well, and I know you were talking about Ebola yesterday and the sort of crisis intervention piece of this, but Reagan and I were in Sierra Leone a few months ago together, and there is no cancer care. Did she mention this? There's no cancer care in Sierra Leone whatsoever, not even in the private sector. And one of the young people that we came across, a young fellow called Monday, he had I think it was Burkitt's lymphoma, so he presented with an enormous tumor that you wouldn't see here, you wouldn't get that big, but it's very prevalent in certain countries in Africa, and often in kids. And so it's very dramatic to see this enormous tumor on the side of someone's face. I'm sure you've seen it. And And we have a cancer care and prevention program in Rwanda. So we decided to send Monday and his dad from Sierra Leone through Amsterdam, because that was a big part of the trip for them. We could sit here for 2 days and talk about some of these stories, because they're all so juicy. And then Monday and his dad spent, I think it was 6 months or even a year in Rwanda. And he got treatment and care. He's totally fine. He's 14 and he's, we spent time with him. It's hard to get cynical. It's hard not to feel optimistic. Now, it's better that we have cancer care in Sierra Leone and we don't have to send every person who needs it to Rwanda. But I remember sitting down and talking to him. I said, what did you think of Rwanda, having flown? Because it's in a very different place, even though civil war in Sierra Leone and genocide earlier in Rwanda. But I remember he said to me, the food was terrible. And of course I made the mistake thinking that might be a sort of similar situation. He said, there's actually a lot of, I was going to get it the wrong way around. I said, really, the food was terrible? He's like, yeah. He said, I remember he said, I'm an African man. He said that the food in Rwanda is terrible. He says, a lot of potatoes. And he said, I like rice. And I remember thinking, wow, it would never have occurred to me that that would have been part of the experience. Okay, I'm going on too long with my answers.
No, thank you. That was very interesting, and I love the stories. I think those are what really you take away at the end of the day, is you remember that person.
Yeah.
That's it's always important to come back to that, and like you said, remember those wins. And one of the questions I did have for you, and I think this can kind of lead back to also speaking a bit about Haiti and where it stands today. I'd love to ask about your career as a social justice worker and global health advocate, and what do you consider in your long, distinguished career something that you would say is kind of one of your bigger wins, and whether it could be a personal win or something for Partners in Health, and sort of leading into this question of where do you see Haiti also now going forward?
One of the bigger wins. Wins tend to be incremental, is what I found, and they build over time. So I think that I have a couple of examples. One of them is a sort of more human, one single person level example. And one of them, I would refer back to this university in, so 3 examples. One is the university in northern Rwanda, which is a very big thing to build and to get behind, but really if you're interested in training and research and gathering research and data and making sure that there's a workforce, you can't only have it based in the UK or the US. The second thing I would say is a win, although a very complicated one, would have been persuading our board that on a dime essentially, or on a very sort of quickly, that we needed to go and help to respond in West Africa during the Ebola crisis, even though a lot of chutzpah there, because we are not a crisis organization, and it's very tricky, as I'm sure you heard yesterday. We did not feel confident going in and saying like, oh, we can do what MSF can do, because we are not in any way built like that, but we knew that we could help with the systems building for the Ebola prevention later. That would be the second one. And the third one I would say, and I'll start with this one on the human level, one of the ones that occurs to me is, this is definitely the long game, is being able to see someone and know someone from literally from when they were born in the middle of this squattle settlement in central Haiti. And this is a kid whose mother was 19 at the time. Paul and I had been working with this community just for a little bit. His mother didn't know it, or certainly hadn't revealed it to any clinician that she was pregnant. She collapsed on, like, in the little area that we were working. It's on a sort of dirt soccer pitch. And when she was taken to the clinic and evaluated and then diagnosed, it turns out she had cerebral malaria and she was pregnant. And our team was able to treat her for the cerebral malaria, which is, as you know, definitely a killer. And then she was taken care of in pregnancy. A son was born, and he then had access to, we were still relatively small at this point, to childhood vaccinations, to healthcare, to primary school education, secondary education. His mom had a job, his dad had a job, and then he actually went on and went to medical school and is now a medical resident, or actually has finished his residency at this point, in a tertiary hospital in the middle of Mirebalais, which is the hospital we built with the government of Haiti post-earthquake with some of the funds. So, that, I don't have 1,000 stories like that, but even being able to say that feels like a big win, born of many, many years of, fighting and pushing. And, when people say to us like, oh, but why are you paying for education? You're a healthcare organization, isn't that mission creep? All of these kinds of things that happen. And we can't pay for education for everyone, but can we try to influence the system so that they can make sure that someone is working with the Ministry of Education to make sure that primary school is not fee for service? I mean, so all of these things. So that, and then, so that I've explained the West Africa one, and then just the university. I would say that's a big win. But I also want to emphasize, we've had so many failures along the way, and we all want to concentrate on those wins, and the stories in between those wins, the nail-biting difficulty, the despair, the feeling at times, really feeling broken at times, because you, like yourself, importantly, you're close to the work, you're close to people you open yourself up to the pain of this work. And that's something I would encourage you. And again, whatever work you decide to do, don't say like, I'm sorry, I'm this kind of a person, because I think it will make you better at what it is that you're trying to change.
I think that's a really great and inspiring place to end, and perhaps maybe we can now turn it over to the students to continue the conversation, because I'm sure they have been sitting on a number of questions.
Sure. Thank you. Thank you.
Thank you both for coming. I first heard about the university during my first year when you were at a panel. So to come back full circle and realize you're going back next week is kind of like very telling. I actually have two questions for you. One was that when you hear about your work and also talking to students of Paul Farmer and his books, one of the biggest things that you hear about is this deep understanding of communities and people, more than really the health part. And I was really wondering how these negotiations happen, especially with the ministries, especially in the case of Rwanda, like how those negotiations happen, and is it more very informal? Is it more about relationships building? So that was one question, because many of us are thinking of where to go to. Should we go into an NGO? Should we work for the ministries? Because I'm planning to go back home to Sri Lanka. So I'm wondering, where you've seen are places of influence. And the second question was, I just heard you joined the MIT Media Lab, where I work as a researcher. So I was wondering what your plans there are and what you think about the institution as a whole, which has some problematic aspects to it. But yeah, just those two.
Sure, and obviously, Jaya, you have your own experience in this, so please chime in. I would say that at Partners in Health, and again, we're talking after 35 years of work in this. So when we were invited 20 years in to Rwanda, we already had an entree. We had a record of being able to get some results. But that wasn't the case. When we first started working, we worked, Paul went there even before he went to medical school. I went there before I was an undergraduate. So we were sort of, trying to understand and spend some time kind of really getting to know the place and some of the people and the history, and reading like crazy about the history of the country. And then we got to know people very much on a grassroots level. And it's and then as we started to get results, then we were introduced to more people. It was not, and I'm not sure I would advise this for any of you to sort of say like, hi, and I'm not suggesting you would do this, but I'm here, and I can join. And it might well be that, especially, after your education here and then after graduate school, that you could be invited back to join, to work at some level in a ministry. But I think it can be a journey. I mean, again, sort of one of the things that we didn't have time to touch on is proximity. So, the other part is if you're only at this level and then you go straight to the ministry, it's very hard to I would so encourage you to spend some time working with people whose lives you may be able to affect by working at a policy level or by working, in a ministry level. Or you can do it in a different order. You could, work at a higher level, do some work there, see what some of the issues are, and then go and see, actually what it is. You know, on a couple of days ago at Partners in Health on Tuesday, we have something called Tuesday Update, and usually somebody who's working not in the Boston office gives an update, and we had an update from the medical officer, the chief medical officer who's working in Malawi, a woman called Emily Rowe. And she's an American. She also did the residency in global health at the Brigham Women's Hospital. And she decided to do it on a day in the life of a CMO in Neno district in Malawi. It was really so amazing. And she talked about, because she said, I want to make sure, because I'm talking to the Boston PAH staff, and you know, our internet goes down, we call our IT guy. If any of these problems happen, we just get them fixed, right? And she just kept delving into human relationships and complexity. You know, what it is, how it is that she has the tools to do that. And in order to do that and be good, when she returns, she will be a much, much better CMO at PIH if that's what she chooses to do in Boston, or, you know, if it gets involved in policy, having an intimate knowledge of what it is to be able to address some of these issues. So I would say that would be part of it, is getting really involved in that sort of thing. On the MIT front, I'm a media lab fellow, and I may be sort of towards the end of my time there. But Joey Ito, who runs the media lab, which is really interesting lab for innovation and that sort of thing. So not sort of strictly part of the usual curriculum of MIT in general, but it's really open to kind of what it wants to do is kind of solve for all kinds of things in design and innovation and that sort of thing, and bring all sorts of disciplines together. And Joey creates these fellows that he brings, and he, you know, asks us to spend time with some of these fellows, sort of helping them to think a little bit outside the box. So, you know, in my cohort, there's a winemaker from Northern California. There's a grandmaster in chess. There's actually somebody who's written a book who spent about 25 years in jail for a crime. So we all get together, and we get together with the students, and it's really a way of kind of tumbling a lot of thoughts and ideas and that sort of thing. Yeah. Wish we had more time to discuss the problematic aspects of it. There are problems with every institution, including Partners in Health, just to be clear. Hi.
Hi, thank you again for your presentation today. So I know you mentioned that PIH isn't necessarily a crisis response organization, but I was wondering about the need to sort of balance between when you do respond to crises like Ebola or like the immediate needs of Haiti after the earthquake, and how you balance that with this need to play the long game and keep fighting against, you know, other things like malaria and tuberculosis. And that came up in the Ebola panel about balancing those resources. So I was wondering how you sort of solve that problem.
Well, and I'd love Jaya's response as well to this, because she's in the thick of it as well, and has seen, you know, these budget trade-off questions happen all of the time. So your specific question plays itself out many times over in this, and certainly in the years I've been as a non-clinician, I've seen it most in most Technicolor around HIV. There was these kind of false dichotomies around treatment versus prevention, as though, you know, well, we should, either you're in the treatment camp or you're in the prevention. You're in that the ABCs. There was abstinence, birth control, and
yeah.
Anyway, I don't even remember anymore, because it's like, why wouldn't you do both of those things? Like, you know, and if Paul Farmer likes to give this example of when he was hit by a car years ago in Cambridge, and it was his fault. He crossed the road. He made a mistake, and he was hit by a car. He was lying in the road, and you know, someone had called the ambulance, and he said, you know, if someone had said to him at that point, he had a very bad fracture of his leg, and someone said something like, if he said, you know, if the ambulance drivers had come and said, you know, I'm sorry, we can only do the prevention here, mate. You know, we can't. You really should have, you're going to have to go to one of those classes and look how you cross the road more carefully. We don't have the money for the treatment part of it. It's even worse with HIV. Like, people would die or they would live. So again, going back to these decision makers, which you know more about, you know, in terms of making these decisions at the high level, I don't think it's a choice. It's a choice in that PH doesn't have unlimited funds, and certainly nor do governments. I think that you have to be able to do both of those things, but I think it's very hard to do a crisis response without having a platform, a health system, the basics of a health system in place. You can do it, like MSF, we do an amazing job, and then they leave until the next crisis. So, you know, finding a basic platform to do the medical work feels important. I don't know what your thoughts are on this.
I think I really became very convinced about this importance of health systems while working in India, because what you find is all these donor agencies, all the people giving the money have their agendas, and that's just the way it's going to remain. And HIV has been the thing that has been funded the most, I would say. But I was actually writing grants for the NGO, for example, on the side, and one of the things that I learned to do was be creative. And I think you've alluded to this in the past as well, is you know, we had to keep doing our routine programming, and a lot of the programming was related to community health workers for maternal and newborn care, but we needed to figure out a way to get them funded. No one really wanted to pay for community health workers unless they were giving contraceptives, unless they were giving ART, which wasn't really a thing in our area, but so we would look at the ask of the grant, and then we would say, okay, they want to fund contraceptives, so we're going to make our community health workers, they're giving contraceptives. And they were doing all of these different preventive things, but we would tailor the grant to each of those donors. So really, I think now the debate is, it was a big debate for a bit, you know, whether we do more vertical programming or health systems. And I think Ebola also was the big lesson that in order to be a responsive health system, we need to have strong health systems in place. We can't just parachute in at the end. And I think the real lesson from Ebola, that from my outsider perspective, is that you know, there wasn't a lot of understanding of the communities, and that's a really critical, important piece of how do we respond. And you know, what are the burial procedures? That was a huge thing. So things like that, I think, unless you have a long-standing and sort of deep understanding of that culture and community, you're not going to be a responsive system. So those are sort of my two takeaways, I would say.
Yeah. Systems, in some ways they sound so boring. You know, just the very notion of just the word system just feels like, it feels like such a heavy word, doesn't it? And you immediately go, you know, you free associate to bureaucracies, and I think about underground pipes, and you know, all of these kinds of things, as opposed to all of this sort of lovely other kind of poetic words. And yet, I've come to really appreciate that systems, there's deep poetry in systems, and it feels actually, you know, I would rather talk about the pipes in the works, because, you know, if you take a place like Haiti, which is hard to believe this, sometimes I can hardly take this idea that it is the place where, maybe actually Yemen at the moment, but until very, very recently, the largest cholera epidemic was in Haiti. And did you know that there is absolutely no municipal water system in any place in Haiti, not in Port-au-Prince, in the capital, where there are millions of people? There is, in order to have any access, so even if you live in the hills and you live in a nice house, your water is trucked in. You pay for a truck to come in and put water in your tanks and all of that kind of thing. So, you know, and most people don't have access to that. So, you know, it's no mystery. You don't have to go to do a public health degree to realize that this is about access to clean water. You really don't. And you could spend a long time reading papers on this. That's all it is. It's that ability to have access to clean water. But what it will take to be able to build a municipal water system under the streets and all of that kind of thing, I mean, we did it in London post 1840. That was all, and you would learn about this in maybe you already know about it. Like, we decided in 1840 to take care of it. Like, and we can't find the resources and the accompaniment and all the things that it would take. And I think someone estimated it would be about $1 billion, something like that, which sounds like a lot of money. It still sounds like a lot of money to me in most respects, until I compare it with the fact that that's what one of the basketball teams costs to buy. Mm-hmm. Just, again, I hope I'm not sounding cynical. But it just, when you start comparing all of these things, you think, geez, $1 billion. Like, I know how difficult it is to raise $150 million for PIH every year. $1 billion for one thing in one place. But how much does it cost to take care of people who are dying from cholera year on year? So, These are big questions, and I would say don't shy away from these big questions. Of course, it's easier to do cholera treatment, but prevention is building a municipal water system, you know, like it or not, and it's not bringing in Poland Springs or anything else in the end. Even if you can dig wells, that might help. In the end, we need in Port-au-Prince what we need it in London, and what all of us have here. These are clangy pipes that you have in this, unless it's changed. It was clangy when I was here. Was it clangy when you were here?
It was.
Yeah.
Hasn't
But next time you hear those clangs in the middle of the night, you're like, oh man, this is so noisy, or something, you hear all that hissing and all the rest of it, think systems. Hi, good morning.
Morning. Thank you so much for your presentation. My name is Hadley Rubera, and I'm studying political science and Africana studies here, and I'm a senior. I have a question about how you raise funds for, partners in health, and for projects that necessarily do not show like immediate returns. Like if you're going to build a school, you can't immediately see the impact, right? Or if you're going to build like systems, you can't immediately see the impact, and yet it requires such a huge investment. So then how do you convince like people to give you money for, projects like those that have a long-term, positive effect? But, usually donors want to see, like, how is it going to affect change immediately after they give you the funds?
Yeah. I bet you see this, Jaya, don't you, in terms of, as a grant writer, as someone who writes grants, that on the one hand, people's attention spans are relatively short, and, depending on the funding mechanism. So with specific donors, with individuals, we can persuade them that it takes a longer time by being able to point to some of the things that we've invested in, the fruits of which have come 10 years later or even longer than that. So it helps if you have a few examples to show. So that part is very important. But for institutions, I think, big funding mechanisms, I'm thinking about some of the big foundations, they really want to see the results pretty quickly and get frustrated if they don't see those results. And I would say, part of that is again, human relationships, being persuasive, not being distracting, but being persuasive. I would say bringing them on as partners rather than just as funders, really thinking about them as collaborators in this, so that, when you encounter issues with it, to be able to say, to be very straightforward and honest, like this is what's happened. One example, again, this isn't specifically on the medical side of things, but there's been a lot of interest in funding reforestation in Haiti. It's a completely denuded country because of the trees have been chopped down, which also accounts for all kinds of issues around, so-called natural disasters. So with this project, they wanted to come back in a year and see it. And what actually happened is that those saplings had actually been cut down as well. And one of the reasons is because people need wood to be able to create charcoal to be able to cook their food. So until we come up with a solution for that other piece around charcoal, I think it's going to be relatively difficult to do that. I mean, you can build fences around, but in terms of a sort of a big solution to the problem, so I would say sort of encouraging people to think with you around those kinds of solutions. But on the whole, finding people who stay in this work for the long term is what we've tried to do. So not think about it. And this is to be candid here, this is something that I wrestle with and we wrestle with at Partners in Health in terms of raising funds. I have never thought about it as a kind of, because we started as a group of volunteers and we built our own organization, all the people who funded us at a level became friends and partners. Many of them are still with us all these years later. So I really wouldn't, again, we have so many people, I'm not friends with everyone who funds Partners in Health, thank goodness. But they, making sure that you don't over-professionalize it as well and then create this sort of weird distance is important too. So I would say it's that, and I would say it's sort of trying to change this, it's really a paradigm into making sure that people don't think that results can happen, reminding them that impoverishment happened over, in some cases, centuries. Like, we often talk about slavery when we talk about the countries that we work in. We go back to that instead of saying, like, you know, people will tend to go straight to corruption. And they miss out all of these important factors of what happens and why resources were removed from a country, and that part, yeah. It's very hard to talk about this work in terms of relatively bite-sized answers, so I hope you will bear with me on this.
Yeah, I don't want to add too much because I want to leave time for the students, but one thing that I've also found, and I think it's a little bit different with an NGO versus with donors, which I've been mostly working with in India, but without naming names, I think there is also now, as these paradigms become trendy, like health systems is the buzzword right now of the day, it's become bite-sized in a weird way. So now even health, and I think research is to blame. As somebody who has just finished my PhD, I think research is really to blame in a large part because we want to do things in 2 years and get papers out. And so now donors are giving money in 2-year chunks, and health systems, as we all know, can be done in 2 years. So I think that's still something that health systems has to, you know, still be the long course and not become bite-sized, which is
no, I think it's true.
Seeing happening.
I think it's true. And have you noticed times when you've been, you know, as a researcher where you've, and as a grant writer, that's, you know, so interesting where, as you said, you have had to be imaginative and creative in your solutions, because grants will tend to push you into silos. You know, funding is done malaria only, HIV only, TB only. And it's like you can't do it in that way. It's a crazy waste of money in the end if you only do that. In the same way that, you know, if we're treated as a whole person, not as somebody with a specific disease, even if we have a specific disease. And I think we have to kind of persuade people around that. Yeah.
Thank you both for being here. My name is Isa. I'm a senior, and I've received some funding from the Women and Gender Studies Department to travel to the Cheyenne River Sioux Tribe Reservation, as well as the Pine Ridge Reservation in South Dakota. And while I was on the reservations, I heard from some elders about the work that Partners in Health does with the Indian Health Services, and I think the Navajo Nation. And I was wondering if you could talk a little bit about that, and also how Partners in Health combines kind of Western and Indigenous ways of understanding health and healing.
Sure.
Can I recommend that we hear the second question as well?
Yes.
We'll race into the clock.
Okay, you bet. And I know that we're having lunch with a number of you as well, so we'll be able to dive a bit deeper at that point. Yeah.
Hi, my name is Aida. I'm a senior majoring in economics and Middle Eastern studies. So I have 2 questions. The first one is about accountability. So how do you ensure that your organization doesn't weaken the role that the government is supposed to play in providing those services like public health? And then the second one is about how you also ensure that you're providing necessities and you're helping the communities, but at the same time you're addressing structural issues. Because as someone who would like to go back to Morocco one day, I was wondering what are the areas you think would be most like efficient to address those structural problems.
Sure.
Thank you.
So quickly on the Indian Health Service. So we work in partnership with a group there called COPE, C-O-P-E, and one of the clinicians that we work with, who at Partners in Health for a long time, actually, Sonia Shin is her name, and she worked with us in Peru in infectious disease. She is the executive director of that group out there, and we partner with the Indian Health Service, who already have a community-based program there, including community health workers and care providers. I have to say that visiting Rosebud and around that area is really extraordinary to see how isolated it is. And we drove sometimes for hours and hours down dirt roads to get to visit with a woman, an 82-year-old woman who's living on her own and chopping wood, and who's, you know, kids are 26 and in end-stage kidney failure. I mean, real issues there in rural, in those areas in rural America. So we've been working out there with a long time, and I'd be happy to give you more information about that, and you can go to the PH website and look at the COPE work. And I definitely encourage you to visit it when you go out there, and I could put you in touch with someone there to talk to as well, happily. And then the second part of your question was?
It was about like Indigenous and Western.
Oh, that's right, Indigenous and Western. Yeah, I mean, one of the things that we have found is that again, it's not really an either or. So a lot of the time, sometimes, not all the time, some Indigenous medicine has arisen in the absence of other forms of medicine. They can exist side by side and often do. And we don't in any way, we don't dismiss one or say, you know, we provide the Western medicine, and then and a lot of the time we found that people don't go to leaf doctors and other doctors if they actually have access to other treatments, or they go and they supplement it, as we all do, with, you know, our own kinds here. As someone, you know, again, I've said this before, but it's really true, as someone pointed out when they were saying that there were all these kind of weird kinds of medicine that was being practiced in these places, and I'm like, well, I know someone who goes and gets crystal treatment here. So if that is not weird, tell me something that is, or Reiki and everything else. And I think that some of these things are in the absence, and some of them feel like they're actually helping us with another kind of thing on top of our access to primary care. And I'm sorry I have to rush that answer. Yeah. Do you want to?
My only, yeah, I just wanted to also add that I think also sometimes it has to do with, again, I work with mostly health systems and governments, and I think a lot of times it has to do with their endorsement of indigenous medicines in terms of public sector. And so in India, for example, Ayurveda is something that's actually incorporated into it. And so there are different doctors, Ayurvedic doctors, that are actually staffed as part of the government. But then there are other things such as traditional birth attendants that are truly rejected. So I think it really depends on what the government, in different states is different. So, yeah. Yeah, it kind of depends on what the government, in terms of public sector, really endorses.
And actually, I know we have to wrap, but actually the maternal care is a really good example of these two things existing together. Of course, traditional birth attendants are good to have, but if you don't also have access to cesarean section and post and pre-natal care, it's really problematic. So, you know, having both of those things, as we do here often, is what I would advocate as well.
Sort of the endorsement is to have them be liaisons.
Yes, exactly. And then accountability, what would be your answer to that in terms of?
Could you repeat your question again?
Yeah, it was about how you ensure that you don't undermine the work that the public sector should be providing to the citizens, right? Because you end up entering this vicious circle if you always have international NGOs that come in and help the people, you know, and then the government is just here and we keep being corrupted and nothing's happening, nothing's changing.
Yes, great question. So I think that's actually a really important question. It's a huge thing that I think has been neglected in public health and health systems. When I worked at the NGO, they had this huge, this principle of basically serving as a place stop. So essentially, we will serve as a parallel government insofar as the government doesn't come and take over the immunization camps, the healthcare here, and then when they do, when they have the capacity to, we will move out of this area. But oftentimes what realistically would happen is the government would get, not complacent, I don't want to say, but essentially they would allow the NGO to keep operating, potentially taking our data sometimes as their own. So I think it's a tricky one in terms of how can NGOs really not supplement, but also encourage and foster good public sector.
I mean, one of the things that I would say is to make sure that the NGOs do work, find ways, small and large, to work with the governments and side by side, and you know, including around data and everything else, because you know, NGOs are very protective about their data, but actually really if their goal is to make sure that there are health improvements in these different places. So that is why we do that around that, so to actually work with governments and to feel like you're a partner with them and to look at it. A lot of the time the health budgets of governments, I don't know about Morocco, but you know, they're tiny. They're $4 or $5, $9 in Haiti. That's like, it's $5 for a vaccination expense to pay for it for kids. So, you know, these are a long, chewy questions, and I wish we had more time.
Well, there will always be more time, because not only lunch, but also we thank you. You know, you come back often, and you have inspired generations of bright fellows. And thank you very much.
Thank you so much. Thank you.